All right, it's a little bit after 12, so we're going to go ahead and get started with today's webinar. Welcome to everyone who is signed in to today's webinar on maximizing the Affordable Care Act in your Adult Redeploy Illinois site. My name is Lindsay Lapointe and I'm the Program Manager for ARI. On behalf of Adult Redeploy Illinois, we're so pleased to convene experts on this critical issue and share some lessons learned from the field. We're pleased to welcome 3 presenters today besides myself. Before I introduce them, I just want to briefly thank Sal Perry, IT staff here at the Illinois Criminal Justice Information Authority for running the webinar infrastructure today. Thank you, Sal. So our presenters today are Cherie Ariozola, a Health Policy Administrator at the Center for Health and Justice at TASC, Craig Cooper, the Director of Operations outside of Cook County from TASC, and he's joining us from his office in Edwardsville. And Katie Welter, who's the Project Manager for the Cook County Access to Community Treatment Court, and she works out of the Chicago Appleseed Fund for Justice. Full contact information for all the presenters is listed on the last slide of the webinar. We'll definitely have the slides and audio of this webinar posted on our website in the near future, and we'll make sure to alert everybody when the audio and the recording is up so you can share it with your team members. Just for a little bit of housekeeping, we'll have some questions and answers at the end. We have some advanced questions that we'll address, and you'll be able to type your questions into the chat bar. You're more than welcome to type them in as we go, and we'll probably hold to the end, but if something's real relevant, we might just jump to it. So yeah, the importance of maximizing the Affordable Care Act. Most people working in the field have recognized that the ACA is a current critical issue in behavioral health and criminal justice with incredible potential for unprecedented access to a range of services for justice-involved people and vulnerable people overall. The ability to leverage the ACA for the justice-involved population holds significant potential to impact outcomes on an individual, community, and state level. Overall, before the ACA, about 1 in 10 of justice-involved individuals were covered with any insurance. And in the next 3 years, we expect a flip to 9 out of 10 justice-involved individuals having access to insurance. The Center for Health and Justice at TASC and TASC overall are really our local and national experts on this issue. We're lucky to have them in our backyard for a second presentation to the ARI network after the training they provided at the 2015 All-Site Summit. Many of you know TASC through their services around the state, but what you might not know is that the Center for Health and Justice has been operating for almost 10 years and is a local and national expert on criminal justice and behavioral health policy grounded in direct work. We as ARI staff have been sharing information with TASC on this issue since last fall, and TASC has taught us a lot, while on-the-ground experience from ARI sites has helped to inform TASC's work. So really, ARI is on the front lines of this issue in Illinois, and we're really pleased to continue that work with this training. ARI is well situated to be on the front lines of this issue in Illinois since behavioral health and justice systems partnerships at local sites are already in full swing and have mutual interest in leveraging the ACA, which we expect to lead to better outcomes and reduce costs. The ARI Oversight Board, which governs the program and itself represents cross-systems collaboration, has been inquiring about this issue for almost 2 years. So they're very aware that it will impact adult redeploy and budgets and programming. Our work shows that ARI sites tend to be innovators, ready to be out front on an issue. Already, we've received timely questions from different sites that have led to important clarifications. For instance, ARI funds have already been used to cover some deductibles for individuals that needed coverage to get access to services. So overall, we really do consider the ARI network a great place to leverage lessons learned, which is exactly what we're doing here today. So I'm going to touch on a few opportunities of maximizing the Affordable Care Act. Number one, it's been up there on the screen for a bit, there's an opportunity to decrease traditional treatment costs in ARI budgets and beyond, perhaps even decreasing treatment costs in probation or other court programs, while increasing access to more recovery-oriented program components by shifting funds. There's an opportunity to increase overall program cost effectiveness, since we know, and I'm sure you know, that treatment has historically been a big budget line item in these kinds of programs. And then there's also an opportunity to improve program and individual outcomes by assisting individuals to get familiar with accessing care for beyond their time when they're involved in the justice system. Sorry about that, folks. I'm going to get back to the correct slide. Addressing the ACA in state fiscal year 16. ARI is trying to take on this issue head on and provide sites with assistance on how to leverage the ACA. On the front end of funding periods, we're now asking for information on the ACA, such as how the program is using it, barriers encountered, and requiring new sites to use the ACA as much as possible. This is an example of something that we're now including on what we call our Exhibit A, which is the program narrative for all our sites. Some of you, I'm sure, are familiar with this and remember addressing this about a month ago in your program materials. The guidance here on this slide was provided not only to continuing sites, but also to potential new sites. And you'll see listed there is what we're asking potential counties who might be responding for a request for proposals. So I just wanted to share with everybody that we're doing our best to prepare counties to address this issue as early as possible. I'm now going to turn it over to Cherie to get into the nuts and bolts.
Actually, thanks, Lindsay. This is Craig Cooper. I'm the Director of Operations for Task Downstate, and thank you for the privilege of speaking with all the folks that have joined the webinar today and truly see the importance of leveraging the opportunities that's in front of us now that's never been in most likely the history of all of us that have been working in the field. Both myself and Cherie Arizola will be tag teaming back and forth on the discussion of the different slides because Cherie is truly our healthcare expert at task and provides the detailed level of information and a true depth of understanding of what the topic is and how that we could best utilize the service that's in front of us. And it's so key at this point that we do make it work, that we do utilize what's in front of us, that the new funding environment is a completely different landscape. It is an environment where those that are not understanding it will be left behind, or more critically, their clients, probationers, will be left without services or the best utilization of services for your particular county or jurisdiction. So it's so critical that we're all at least discussing what's in front of us and really trying to learn the new languages and environment that's before us. And common terms, we're all used to the terminologies, the acronyms, that's all within the criminal justice system, the treatment system, and we're learning new terms as we're delving into the area of Medicaid and to the area of managed care organizations. The FFS, fee-for-service, is one of them that we'll be mentioning, but it's those areas around the state, typically in rural areas that may not have a managed care organization for those particular counties. And you'll see later on in the slides which areas those are. And if you want to think about it in lay terms, that's what would historically have been typical Medicaid, old Medicaid kind of situations that was before the ACA. The managed care, the MCOs that we're making reference to, if we want to think about it in terms of our own health care, all of us in the system working for either agencies or state entities or court systems are very much familiar with how we manage our own health care with our own insurance providers. It's equating that knowledge, that understanding of how insurance companies navigate and work and how we ourselves utilize those insurance benefits in translating that into this new environment with our probationers, parolees, clients that we're dealing with in a treatment setting. Terms such as also prior authorization are common in the language of this new environment. The process of, if you're in an area with a managed care organization, they're managing specifically the care for their members and the best utilization of the funds within that plan. So they're looking at, just as your own private insurance would be doing, prior authorization for services to be rendered is a hurdle or a step that needs to be gone through, and a process to take place is just common practice. What we've got to do, all of us collectively, it begins with our clients, our probationers, folks involved in the court system enrolled. That must be common practice in our intake procedures, the first point of contact, the earliest point of contact with each individual to best leverage the resources at hand is finding out crucial information if they're enrolled or not and making steps to get them enrolled. Those steps are simple in nature. Several locations around the state have had the foresight to begin to structure their court system, probation department, other areas of service delivery, and partnering with agencies to provide application assistance or application assistance directly. And it could be as simple as setting up terminals within a waiting area of your waiting room at probation departments, areas within the court system. What was once an expensive venture, now with technology and the advancements of different products, you could very at low cost be able to set up terminals for internet access, telephone access, and so that the clients and probationers be able to get enrolled at a much faster pace so that the whole process of the next step of utilizing those services can begin.
Craig, can we go back to the last
if you'd
slide?
like to take it away. Absolutely.
Yeah. So this is Sheree Ariazola from Task. So I don't know if some of you are aware, but as far as the partnering with organizations who have made providing application assistance a part of their operational practice, so funding for state funding for navigators has ended. However, there are a number of organizations who will still be providing application assistance as a certified application counselor, or CAC is what they're called. Additionally, in the fall, the federal government will be announcing their awards for navigators, and so that award will span over 3 years. And so in addition to using navigators, there's also the option of providing assistance directly to your own clients that you work with. And you do not have to be a navigator or a CAC or IPC or ABC or however you want to say it. You don't have to be certified to provide assistance. Anyone can provide assistance to someone with their application. A family member could provide assistance, and in the same way, an organization could help people apply. And what we at Task have done is sign up as a community partner on the ABE website. And it's really simple. It takes 2 minutes. And then just I have provided training to our staff on troubleshooting issues and how to go about it. And so that has worked for us. And as far as the future of navigators and that being uncertain, it might be a route that you all might want to take. And it's not hard, especially for people who are single without children. Applications are pretty straightforward. And lastly, the third option is just providing at least a telephone or a computer for someone to sign up themselves. And so I just kind of wanted to talk about that when we discuss how to enroll clients. So for the next slide, so the first step is enrolling clients. The second step is to track Medicaid coverage status and managed care plan status. So in order to maximize the ACA in your site, you will need to do all three of these things. Unless you live in an area where there is no managed care, then you'll just need to be tracking Medicaid coverage status. And so knowing whether or not a person has Medicaid and not just relying on self-report is very important, because if the client ends up being correct, then everything's fine, especially if you're in a fee-for-service area. But if the client is incorrect, then you're not operating with accurate information. And if this is particularly important if you're in a managed care region of the state, because you need to know what type of Medicaid someone has, what plan they're in, because that's going to dictate where you can send someone to. And so you really have to have that information. You can operate without it, but it will be like walking around in the dark a little bit. And so obviously there's, how do you find that out? There's relying on the insurance card that someone will get, which will, if you're in a managed care area, it will be specific to that plan. So Blue Cross will have their own card, County Care, Molina, etc. There's also the Medi system, which is the medical, exchange information system, and it's run by HFS. And it allows providers to look up the status of individuals to see if they have Medicaid and what type of coverage they have. And so if your site is in an area where Task operates, Task has the ability to access the system to look up all of our clients. Providers also, if you're working with closely with a provider, they have the ability, but it's something that you will want to know, especially for probation officers or case managers when they're trying to connect people to treatment. Finding out which providers are operating in Medicaid and which managed care plans they have contracts with, that's important too, to understand where you can send people to, and so that we might all be used to using, but then there's also this unknown network that we might not know about, and some of those people might be willing to work with us. And finding providers that have contracts with multiple plans works the best, because then you don't have to sit here and really try to figure out which provider has contracts with which plans. You could just send your clients and know, oh, this person is operating in all the plans. And I know that's not really ideal in Cook County, but in regions where there's only two or three plans, it might be something that you can find, a provider that has contracts with all three of those plans. I'm going to pass it back off to Craig to talk about what Medicaid covers.
All right, well, thanks, Sheree. And yeah, it is critical that we're having at least an understanding of what is possible to be covered. And there's a variety, you can see on the slide, of items, service delivery for clients, assessments being one, outpatient, intensive outpatient, the medically monitored detox, residential treatment, but specifically for those facilities with 16 beds or fewer, and that's current status. A lot of these items that may change down the road, a lot of that can be fluid in terms of coverage and not coverage, but they must meet the medical necessity requirement for any one of these levels that we're talking about. Also, if you would have that you're looking at what can be paid for, think in terms of your enhancements for your problem-solving core could better utilize funds if you've got a different payor, such as Medicaid, that could enhance your program by the expansion of use of medications within your problem-solving court, not only the psychotropics, but your buprenorphine and Suboxone, naltrexone, and Vivitrol. Understanding the ability that can be a paid element, making sure that if it was a naltrexone or Vivitrol, an easier process of getting the physician's engagement. There's less hurdles because it's not considered and listed as a narcotic, like the requirements with a buprenorphine or a Suboxone, where they have to go through the number of hours of training and to get in this 3-digit DEA code for their prescription. So, but understand that can be something that be utilized for enhancements, and that you would be able to use ARI funds that if we're in a different directions and carve out Medicaid for using it for this specific use. As well as some managed care organizations will also have the ability to take care of some transportation needs of a probationer, maybe access to getting them into treatment back and forth. So the understanding of what your particular managed care coordination of benefits, what they're able to do, can really offset expenses in another part of your budget. What also we must understand is not only what they can pay for, but what they can't. Residential treatment in facilities of more than 16 beds, and the key element here is no service is rendered by a non-Medicaid certified provider. So that's part of our advocacy as a group entity within the criminal justice system and treatment system of communicating with those treatment partners, making sure that they're making steps towards a better service delivery model, making sure that they have Medicaid certified facilities and they're able to do service delivery in that fashion.
So we talked about, or Craig talked about, what Medicaid can pay for, what it can't pay for, and now we're going to talk about what will it pay for. And when I say what will it pay for, even if a service is technically covered, it doesn't mean that a managed care company is going to decide to pay for it. And so in an effort to control costs, they look at many services under the scope of whether or not it's medically necessary. And so often this is the case where someone will want to place someone into residential treatment, and they will not approve that, but they will approve intensive outpatient treatment. And this has been what I've heard, at least, and I think other people have heard across the board, that it's a lot easier to get people into IOP than residential treatments. And so that leads us to the point is that, you know, using ARI funds as a reserve for services that are not covered, which I'm sure many of you are already doing, but trying to really use Medicaid for what it will pay for and not using ARI funds for what Medicaid will pay for, I think is what we're trying to accomplish here. And so, of course, not in all one sweep, we're just going to totally transfer all of our ARI money into Medicaid, but we want to tap into that to as much as possible, especially to kind of coincide with the shift that's occurring right now. With a lot of state budgets, you know, a lot of agencies are not going to continue to fund uh, treatment services for someone who has Medicaid coverage, and even the state um, lawmakers, you know, want to, you know, with the lack of funding and the lack of revenue, they want to tap into those Medicaid funds, which are 100% reimbursed by the federal government, up until I think another year, and then it drops down to 90. So, of course, this, you know, we still want to work on educating managed care organizations on the justice system and why people need services immediately upon release. And Task has been doing that with various managed care plans, and we continue to do that because while this is the reality, we, as justice system partners, want to shape what happens in the next few years because everything is so new at this point, and we want to try to influence it before all this policy becomes rock hard and solid. And so I just wanted to state that even though this is the way things are now, we're behind the scenes trying to advocate for policies that better help clients get access to care. And I will pass it back off to Craig.
Thanks, Cherie. A key part of moving forward with this new landscape is establishing new relationships with, and I think they are, is key as the pool begins to increase. The number of providers is projected to be increased. The number of new individuals that are now on the scene will be a new part of your community. And as you're thinking about enhancing programs or a shift, hosting your meetings in terms of planning, to invite them to come along. Invite those new members that are in your community that may be Medicaid certified. They're new possibly to the other members of your team. But that's one of the few ways that you're going to be able to get them engaged, and see how you can communicate back and forth, inform them about your program, see what they have to offer, and bring them in on a regular basis to look at. Currently, Task has mutual service agreements and hundreds of treatment agencies throughout Illinois, and we update those on a regular basis. Part of our planning for our infrastructure to meet the demands of the changing funding stream is our technology and our new agreements and monitoring the changes within each one of the treatment agencies to keep up with either their new contracts, their new relationships with managed care organizations, and to know at a click on the computer screen about what they have to offer for clients who are involved in the justice system.
So you might be asking, okay, how do we find these new providers? And so there's no one way to go about finding these new providers. And so we want to offer a few strategies. In an ideal world, there will be this nice, convenient list for everyone, and it will tell us, you know, which providers offer MAT and which providers offer this and which providers are in what plans by which county. But we're not there yet. And so for now, one way that has been, I think, a way that a lot of people have been doing already is surveying the providers you are currently using to determine which ones are operating Medicaid, obviously, and which ones have are working with managed care and what managed care plans they are working with. And so Task did this with its highest volume providers. And that information was really helpful. During that process, it was very interesting because some providers weren't really sure which, you know, depending on who you asked, they weren't really sure who they had contracts with. So it's important to know that there's so much change going on right now that even at the provider level, what you might hear from a CEO or from a high-level person compared to what you might hear from a frontlines intake worker might be two completely different things. And that, just like I said earlier, with confirming whether or not someone has Medicaid, self-report sometimes isn't the most reliable method, but it is a method, and so we're not going to cross it out. Another way is to use each plan's provider search tool located on their website. Each managed care company that operates in Medicaid has a provider search tool, and it will allow you to search for behavioral health providers that they're contracted with. And so we'll get into how to do that. Some of you might already be aware, some of you may not. It's not difficult, but I thought it'd be a good opportunity to have us all share information and become familiar with the tools that are at our disposal. Lastly, there is the SAMHSA's provider locator. It shows you all the plans that take Medicaid, all the providers who take Medicaid across the states and country, but it doesn't include what plans they're with. So this might be a useful tool for areas who are operating in fee-for-service to find out who just accepts Medicaid. I also wanted to mention...
Also, Sharia, one...
Go ahead, Craig.
Go ahead. Okay, I just wanted to also mention within TASK, if you're partnered with TASK as part of your either ARI group or your court system group, statewide we have the ability, and we're utilizing it in certain areas that have interest, a provider portal. The provider would be given an ID and a password, and it integrates services, and so there's a seamless connection between task and provider as well as the court system. The criminal justice portal is also available so that the court system personnel, whether it be probation, the judge, or other entities involved in your team, can have ID and password and access to specific what's going on with their defendant or probationer within their system in live time, whether that be the treatment progress, whether that be toxicology results, or services that are going to be able to be provided through Medicaid reimbursement or other types of reimbursement. So that's also another available possibility to work with providers.
I also just want to reiterate that providers must be Medicaid certified in this new world. And if you're in a managed care region, they must have contract with managed care plans. I wanted to note 2 exceptions to that rule. One, if there's a lack of providers in a network, whether just providers in general or lack of a special type of provider, a provider can request a single case agreement to the managed care company to treat the member and to get paid even though the provider is technically out of work. And so this is common in rural areas when there's a lack of, or even other areas, but there's not a lot of specialty type of providers. This is a tool that you can use, and I think some jurisdictions have used it. And the other exception is that if a person was enrolled into a plan, but during that time they were seeing a provider while the switch occurred, they legally can continue to see that provider for 90 days, even if the provider is out of network. And so, of course, they would have to do this in conjunction with the plan, but it's another exception. Additionally, every year, people who are in managed care have to decide if they want to stay with their plan they're in or if they want to choose a different plan. And when they get that letter every year, the timing will be different for every person and for every county, depending on when they first signed up, but it is something that happens every year. And so when they get a letter from the states, it'll tell them they have 60 days to choose a plan. And then after that 60 days, if they chose a plan or were automatically enrolled into a plan, they then have this 90-day window that I just mentioned. And so if you think about it, you have a 5-month window of opportunity to have a person choose a plan that has more providers in it and it works better for that person. And so that's something to think about if you are dealing with clients who have a plan and it's just not really working for them. You might want to encourage the client to choose a plan that has gives the person more options. And I've heard that that is something that a lot of case managers and other people are encouraging, without directly, of course, steering anyone into any particular plan. So now I want to just show you guys what I was talking about earlier about how to go onto a managed care website and see what providers they have in their network. And so I am going to switch here. I have Meridian, but I think I'm gonna go to Molina actually. And so I can make these websites available later, but I'm just searching Molina here, if I can type correctly. And you know, so each managed care organization will have a site like this. And you want to look for something that says find a doctor, pharmacy, or sometimes it'll say, you know, provider search directory or something like that. So you go there. I opened up a new window. I hope people can see this. Yeah, I will just. Okay. And so most, all plans will have some type of function like this, and you can search by city, by county, or a near address. And so should we pick a county? You want to make sure you put Illinois. Obviously, oh, the computer didn't freeze. Illinois, okay. I guess Illinois City. I'm gonna choose Edwardsville since that is where Craig is right now. And distance, let's just be generous, 50. And so it's important that you choose the correct plan. Like Blue Cross Blue Shield is obviously works with employers. They work with a lot of different people, and so you want to make sure that you're filtering out to the correct audience or to the correct plan. And so in Molina, they service people with disabilities, seniors, and so we want to make sure that we select Family Health Plan, which encompasses ACA adults. If you want to look for these other types, you can, but most of the time clients fall into this category. And you want to select behavioral health and social service providers, although there's a bunch of other providers that you're. And I usually leave this stuff blank. Sometimes I feel like when you mess with this, it filters out something that you might not want to have filtered out. So this is usually sufficient. And then it'll show you a list. It'll tell you the distance, the name of the provider, the address, which sometimes will have, you know, the name of the actual organization instead of just the name of the actual physician or healthcare worker. Phone, specialty, so, you know, psychiatry, mental health, they'll have different specialties. Ideally, you know, it would be down to the type of level of care they provide, but this is what we have for now. The language and the gender. It also has a little map down here, and some websites will let you download or print this list. This one, it doesn't look like this one allows you to do that. I found this search to be easy to use, and so I can show you what a geek I am. I went and took this survey and gave them kudos. So I want to do one more just to show you the difference, and I don't know if I should do one where if I should do Blue Cross, so you can see how it's kind of complicated because they work with employers and things like that. So let's go there. Blue Cross Blue Shield of Illinois. This is the wrong one, actually. Let me go back. Don't go to the ad. Go to this one. Okay. So you want to find something that says find a doctor or hospital. And so we'll just put a doctor, and then once we do that, it should give us options. Provider finder. Here we go again. Okay, so you have Illinois, start search. And then here again, as I said, they have a bunch of different plans, and I don't even think that the Medicaid plan is in here. And so, like at my job, it would be Blue Advantage HMO, but it doesn't even look like Medicaid is in here, but it is definitely online. So I'm going to go back. The Medicaid plan for Blue Cross is called Community Family Plan, and so it's important that you get the right name. And I should probably, as a follow-up to this, assemble all the right websites. But you see how it's different here, because this is the Medicaid plan, and so you want to make sure you're looking at the right search engine. And I was on the wrong one. So find a doctor or hospital, provider finder. And so here it's a little different, but it's pretty much the same. You want to go type behavioral health provider. I usually leave specialty blank, address, city, or zip. I'll put Edwardsville again. I don't know, they don't operate in Edwardsville. I'll just put Chicago. And so here I have a list, and it was a little different, but it's pretty much similar. It has the names of different doctors here. Sometimes it'll have the name of an actual organization versus just a single family practice. And so obviously in the justice system, we're used to working with organizations. And so I don't want to rule out these single providers, but working with the organization is usually ideal. And it doesn't look like these ones are that, although it might just not show it. And so some of these searches aren't ideal. Let me see if there's a filter. I don't see any. This one allows you to print this page, and you can see it says 1 through 50 of 378. And so thank you for your patience with that tedious exercise, but I just wanted to get you all familiar with this tool. And we are currently in the process. I have an intern from University of California at Berkeley who's working on pulling all this information from all the plans across the state. And so just to see how we can use this tool for our staff and everyone in the justice system. And I know other areas are doing what works for them. And so it's not perfect yet, but we're trying to do what we can with what we have. How do I go back?
Can I do a
Sure.
This is Lindsay, and this question jumped out at me about when Cherie was walking through the live provider search. Clearly, it's complicated, and clearly all the managed care organizations have a different setup and a different user interface for their search. So it's a little complicated, especially for people who, this is new for people. So my question is, if a jurisdiction is so lucky to have grant-funded provider navigators, would those folks be expected to be familiar with these managed care provider search websites?
I'm not sure what they're familiar with. You know, for navigators, their main function is to enroll people into Medicaid, and it's not necessarily to refer people to treatment or refer people to services. I mean, I think in an ideal world, they would be funded to do that, and that would be wonderful. And I think, but they're not technically, that's not technically their sole purpose. But that's not to say that navigators haven't evolved to become more fluent in this type of stuff, and I think they need on this type of things. But I can't say whether or not they know about this search. I know I talked to someone from the Cook County site, and she was already using this. She was younger, so maybe she's more internet savvy, and she's like, oh yeah, that's online, no big deal. So I think it's really just about collecting and honing and harnessing all the stuff that we can, you know, because we're not living in a perfect world. And so as I said, we're trying to get this information to an Excel type spreadsheet to make it easier. And so I know this isn't ideal, but it is a tool that we have in our tool belts, and we're trying to, as a collective group, work with each other to get better at this. So the next slide is guidelines. So I just wanted to recap what we talked about today. So when we talk about maximizing the ACA in your ARI site, I wanted to just go over all of these guidelines, I guess you could say. So when they say, what do they want us to do? What do they mean by maximizing ACA in your ARI site? If you want to just kind of come back to these whenever you feel like you're lost and you don't know what to do, I mean, I think sticking to this, I think we'll kind of, you know, okay, focus on this, focus on that. What do we need to pay attention to? What are we doing well already? And so some of you all might be enrolling clients and everything works great. You have a navigator who you're working well with, or you don't really have a problem in the area, great. You might want to work on tracking Medicaid and managed care plan status. If you have a good understanding what Medicaid will and won't pay for, you can maybe focus on establishing relationships with new providers. Or if you're good with the providers you have, then you can start maybe expanding this into an area like health literacy or redetermination, or things if you want your clients to keep their coverage. Because it's not just about enrolling them, it's making sure they don't lose it, because every year they're at risk for losing it if they don't fill in the right forms and return those back to the state. But that we could have a whole nother webinar on that, so let's not really go there unless you guys have questions. So I assembled some reference materials just so that later you guys can save this PowerPoint and go back to this if you ever want to reference some of these, and I'll go over some of them. And so at the Offsite Summit, this was included in your folders, I believe, and it just gives you a visual of what happens over the course of a year from the point of an application to the point where they're waiting for it to be approved or not. Then for managed care areas, this is when managed care comes into play, how long they have to switch, and then just regular coverage in their Medicaid managed care plan. Then it talks about redetermination here and when that happens. And then, and so this is just a good kind of visual that shows you what happens over the course of a year. I want to go into more detail. How are we doing on time? Good. Half an hour.
Yeah, if Katie and I can start about 6 minutes.
Okay, I think this is the last thing. So let me quickly go over this map. We also went over this at the ARI All-Site Summits, but I just wanted to go over it in more detail. So the shaded areas here are what we call the managed care regions of the state. And those regions indicate where managed care is mandatory for everyone who has Medicaid. if they reside in one of those shaded regions, they are mandated to go into managed care. And if they don't choose a plan, they will automatically be assigned to one. These non-shaded areas represent areas that it is not mandatory that the people who have Medicaid in those areas be in managed care. And usually the reason for that is because in order for there to be managed care in these non-shaded areas, there has to be more than one managed care plan operating in that area. Otherwise, you're forcing someone to go into this one plan, and they want to have people to have a choice at least. So there has to be at least 2 plans operating in an area in order for them to have managed care. And so in the areas where there's not any county shaded, you might see some of these symbols and ask yourself, well, why are these symbols there? In these areas where there are symbols, it usually means that there's voluntary managed care. And in those areas, a person who is on Medicaid, if they have these symbols, they can choose to pick that one plan who operates in their area. But they can also opt out of it. Whereas in these areas, they don't have a choice. You see a lot of different symbols. There's ACEs, there's CCEs, and these are just different models of care coordination. ACEs and CCEs are phasing out, and come January or so of 2016, this map will look different because there'll be a lot less symbols. You'll just see a lot more MCOs and actually no more ACEs or CCEs. And so ACEs have been encouraged to contract with managed care organizations, and that's what they are doing. I think one has is already on track to become their own MCO. I think that's Advocate Accountable Care, but I'm not certain. The state has said that they expect most other ACEs to follow suit. And so, so that's that. In areas where there's no symbol or and no shaded, it's just regular fee for service, and you can utilize the SAMHSA provider tool to see who accepts Medicaid. I've also put this information in the chart. And with that, I'm going to hand it back over to Lindsay to hear from what ARI sites are doing in this area.
Great. Thank you so much, Cherie. We wanted to highlight one of a few ARI sites, or actually 2 ARI sites, that have reported a significant decrease in their treatment budgets due to the Affordable Care Act. So we're going to hear from one of the programs in Cook County, but we're also going to hear from Bridgeway in the 9th Judicial Circuit in Knox County. Bridgeway is the treatment agency that provides the treatment to the drug court in Knox County. And I worked with Vicki Rose, who's a director at that agency, to get this information so I could provide it to you. And basically, we're going to share some nuts and bolts examples of how Bridgeway has managed to maximize the use of the ACA, and a lot of it aligns with what Craig and Cherie have been talking about on a general level. So prior to the Affordable Care Act, at the Knox Drug Court, ARI funds provided treatment for the Knox County Drug Court participants at a rate similar to the DASA rates, where the participants did pay a small copayment. Most of the drug court participants simply had no insurance at all, which I'm sure is no surprise to anybody. After the ACA rollout, most of the drug court participants became eligible for Medicaid and or other health insurance. Bridgeway has seen what they call a flip-flop in the utilization of funding for both drug court and ARI involved clients and other clients that they're seeing that are low income. Clients are no longer utilizing ARI or DASA funds, and about 80% of the drug court, which are the ARI clients, have either Medicaid managed care or private insurance now. So I like that term they used, flip-flop, and then they gave an example of how it's actually occurring. So how did they make this happen? Well, certainly they communicated a well-planned process. In terms of education and enrollment, both Bridgeway and counselors at the Knox County Health Department began the process of enrollment by first educating the clients on what the ACA is, how to sign up, and the benefits to them, including behavioral health and physical health needs. They worked hard on this client education on the enrollment process and communicating the benefits of coverage to the clients. In terms of local managed care organizations, here's where they fall in the state in terms of the map that Cherie was talking about. So Bridgeway is located in a managed care area for Medicaid, and they have several managed care companies that their clients can choose from or that they're placed in if they fail to choose. So checking that Medicaid or managed care status has been worked right into Bridgeway's process. They use MediCheck, the state website, to confirm Medicaid, and business staff at Bridgeway checks that prior to every appointment, and they have to check it prior to every appointment because there are frequent changes in coverage without notice to Bridgeway, the provider, or without notice to the client. Bridgeway has the client provide their card for their records at the start of services, and then they do a financial update every 6 months to re-verify income and insurance. So those are all examples of how Bridgeway has really worked this into their day-to-day process. In terms of the importance of collaborations, they've really integrated the discussion of funding into some aspects of the drug court collaboration. As you can guess, Bridgeway frequently communicates on every aspect of the ARI program, and again, it's a drug court in Knox County, but now they make it a point to talk about funding where that's appropriate. And as with most drug courts, the team members are in contact on a daily basis. So I just want to touch on a few major challenges and successful strategies. In terms of active, and I'll emphasize, active collaboration with managed care organizations, Bridgeway told us that that's been really critical. Bridgeway works actively with those managed care organizations to communicate client needs and to be very clear on what the managed care organization requirements are for billing and payment receipt for the services delivered. And of course, those requirements can vary by whatever management is. There are provider representatives for each organization that Bridgeway contacts, and each client has an assigned care manager. But as you might expect, not all the clients are aware of these care managers, and not all the clients know what it is or how to use it. Shifting policies within managed care has certainly been a barrier. Bridgeway's struggled with billing managed care Medicaid companies because they all have different rules and they can change the expectations for authorization and pre-authorization without notice. Clients often don't know if and when they're enrolled in Medicaid or one of the managed care organizations. And that touches on a lack of familiarity and knowledge from the client perspective. And I'll just, before I turn it over to Katie Welter to talk a little bit about Cook County, just to end on a positive note, Bridgeway did note that once clients were aware and were educated on the ACA, a lot of clients ran with the process and started initiating the process on their own and really actively accessed care. So that's the update from Bridgeway in Knox County. I'm really happy they were able to provide that info because we have a lot of different jurisdictions in Illinois and we wanted to make sure we heard from more than one. So I'm going to turn it over to Katie Welter from the Cook County Act Court.
Thank you, Lindsay. Thanks, Cherie and Craig. My name is Katie Welter. I work for Chicago Appleseed, and one of my major roles is to manage one of Cook County's ARI programs, the Access to Community Treatment Court, which is basically a felony drug court program with an emphasis on, treating clients and linking them with an array of services in the community from the beginning of the program. I just wanted to share with you some of the strategies we've been using during the Medicaid expansion period over the last year and a half that the court has been running. And these are going to sound familiar, and I hope to just give a little detail on top of some of the things you've already heard. But the major strategies are to, as you've heard, add insurance enrollment to your workflow, to partner with collaborative and sort of ACA-friendly providers. Be realistic about participant performance pre-treatment. That's been a big one for us. And then also to focus your bridge funding, your ARI funding on non-reimbursable services. So to start with, just to reiterate what everyone has said today, it's really essential to include insurance enrollment as part of your program. If you have a planning grant or a regular steering committee meeting, this is a good kind of task to bring to them, where you have lots of stakeholders present. The ACT Court was very fortunate that our program was sort of born out of a larger justice and health planning process led by TASC and the criminal division of the circuit court here in Cook County, where we actually looked at every single point along the criminal justice referral process and determined ideal points to enroll, and then kind of recheck enrollment, and then also redesignation. So in Cook County, during the jail intake process, people are offered the opportunity to enroll in insurance, and then when they make it to the ACT Court, their case manager is assigned to kind of check the enrollment status, work with them to complete anything that still needs to be completed in their application, and if they are enrolled, identify their managed care provider so that they can start making a treatment plan right away appropriate to their insurance status. And just remember, I mean, if your county is like Cook, a lot of our participants have never had insurance before, and so this isn't just about, you know, doing the work for the client or the participant. It's about educating them as well, and so it's very important that the staff who are assigned to this role have some basic training and insurance knowledge, and I think the slides in this webinar itself would be ideal for that. So that's just especially important. You're not going to get anywhere without that enrollment and continued insurance status. Another part of this whole expansion has been just being realistic about how to work with the clients before they access treatment, and I'm sure that's always been an issue, but this is sort of about dealing with the new Medicaid environment before clients are able to use their Medicaid for the services they need. So delays are still likely, and that can be due to enrollment waiting periods or lapsed coverage like we talked about, and of course capacity issues. And during that time, if you have clients, as we do, who are substance dependent or who are severely mentally ill, it's just really important to remember that they will not recover without treatment, and it's unrealistic to expect people to stop using drugs or stop using alcohol or stop experiencing their mental illness symptoms without that treatment. And that can be a challenge for the staff and the court team, of course, and that's why it's a good idea to tailor sanctions and rewards to attainable goals. So if any of you have had seen Doug Marlowe give his talks about evidence-based practices with sanctions and rewards, some of the attainable goals early in your program would be, you know, showing up to all of their important appointments, court and probation, making that first treatment assessment appointment, and also just being honest with staff and the judge about their behavior, even if it's negative. And it's a great way to establish trust, even in the face of some ongoing noncompliance. Also remember to, you know, use this as an opportunity, the Medicaid enrollment process as an opportunity to reward people, recognize the accomplishment they've made when they do enroll successfully and do start using their insurance. That's a big positive. It's a good idea too to just stay in more frequent contact with your participants before they begin their treatment process. And just, it really does not help to sanction harshly or terminate people for continued use alone if they aren't engaged in treatment or if they haven't completed a meaningful number of hours of treatment. As you've heard several times today, partnering with collaborative providers is really essential. It's a drug court best practice to work closely with just one or two providers. That may be all you have in your area. In Cook, we have a lot of options, but what we basically did was try to identify a provider who was what we kind of think of as ACA friendly. And that's not just about being Medicaid certified, although that's certainly essential. We've worked with providers whose administrators are getting educated about the ACA and committing to training their own staff. They're also involved in advocacy through membership of associations. And just to meet with those providers in person, ideally, invite them to your program, go to their site. If the judge can be involved, that's especially powerful. It's a really positive signal from both sides that this is a major priority for both of you. And just remember that, we're all trying to maximize the benefit of this law and of Medicaid for the benefit of our shared clients. We're all serving pretty much the same population. It really helps after these meetings too to write down what was agreed upon. And it doesn't have to be super formal. You don't need a new contract. In fact, in the early days with the ACT Court, we just kind of emailed back and forth, well, okay, so this is our contact person, and this is your contact person, and this is how we're going to make referrals, and here's how often we need reports. Are we all on the same page? Great. That'll do the trick in the beginning. It's been very helpful for us to ask providers to designate someone to be our contact for our clients. We've also asked providers to use unique billing codes, which helps us track information and just make sure we understand where our clients are at with them. Just being patient in general goes a long way. Remember that your staff are learning this new environment, but so is theirs. That generates a lot of goodwill, especially between the back office staff and your staff. And then if you're having a really positive relationship with a provider, by all means, I think that's a great criteria for thinking of contracting with them for services that Medicaid doesn't cover. Which kind of leads us to the last point, to maximize your ARI money, your bridge money. You really want to target those ARI funds to bridge the gap between reimbursable and non-reimbursable services. And those non-reimbursable services might include housing, case management, drug testing, residential treatment, cognitive behavioral therapy groups, or transit assistance. All of these areas, our clients deeply need these things. And generally, they're not covered by Medicaid with the exception of residential treatment and, to some extent, case management and cognitive behavioral therapy, but not to the extent that we might like. If you identify a provider as a range of services, that's great. It'll give you some flexibility because you can enroll someone in residential treatment, which you might be able to pay for out of the bridge money, and then they can transition into outpatient where the Medicaid kicks in, and then you have a nice continuum of care at a little bit lower cost than if you were contracting with a provider that didn't have any Medicaid certified services, for example. Don't be afraid to review the invoices you're receiving in this new environment very closely. In the ACT Court, I myself review all of the invoices we receive before they go on to the administrative staff for the county. And what I do is I just look to see, I look to see that all the services match up with my understanding based on the case management reports. And I'll check with the case managers to see if the insurance status has changed with the individual clients, because if it has, they may be able to, the provider may be able to bill the insurance back to the beginning of treatment. In other words, it's not uncommon to see on a bill a service that could be billed to Medicaid but wasn't, just because of an oversight, because it's a complicated new environment. So don't be afraid to ask questions. Don't be afraid to ask, hey, I see this service on here. I thought it was covered by Medicaid. Is it or is it not? Also, it helps, I think, for budgeting purposes to track treatment spending and savings. One of the providers we work with, on their invoice, actually breaks out the costs that are billed to the program, and then also the costs that were billed to Medicaid, which allows me as the project manager to communicate that to a variety of parties, saying, well, this is what we're saving. I think that's really useful, and as I understand it, it's not terribly difficult for the provider. I just wanted to give you an example of how the ACORD is maximizing our bridge money. So just a little story about a person who's typical of the ACORD. John is chronically homeless and dependent upon opiates. The local treatment provider offers non-reimbursable residential treatment for up to 28 days. But they also offer reimbursable intensive and basic outpatient treatment, as well as non-reimbursable recovery homes for up to 90 days. So we're going to compare the cost here, cost to the program, of 28 days residential treatment to 90 days of outpatient plus recovery home. And on the left, you can see residential treatment for 28 days is $3,940, but outpatient plus recovery home for 90 days is just slightly higher than that at $4,198. And what we've been finding with some of our clients is that the 90-day option with the outpatient combined with recovery home can be a big help to people, more than just the 1 month in residential. And if we can afford it, we can combine the two, which is, that's super. But you might get focused on, oh, this person absolutely needs residential treatment, but the more cost-effective and possibly even the more effective approach can be longer treatment period that's a little less restrictive. So that's all I have for you. Feel free to contact me. My information's at the end of the slides, and I'm happy to talk about what's worked and hasn't worked for us here in Cook County. Thank you.
Great, thank you so much, Katie. I think it's really valuable to hear those two different and yet somewhat similar perspectives from two very different parts of our state. So we had scheduled the webinar to go until 1:30. We do have some advanced questions that are on the next few slides, but we also want to give opportunity for anyone to type in questions that might have popped up during the webinar, or you can take a few minutes now and think of questions. As you know, we're quite accessible, and we hope that you'll questions in the near future as well. So feel free to type in, and in the meantime, we'll move to some of the questions that we got in advance. Okay, so one of the questions we got is that a client now has Medicaid insurance, but they need residential treatment, which not only has a deductible ranging from $500 to $5,000, but also a copay. Most clients do not have the money for either. So are there any funds available for these expenses?
So you can just, so there's really no one way to answer this without knowing all of the details. A lot of the times when we get questions like this, it's what we do internally at Task is go to the source, ask clarifying questions, to really determine the root cause of a lot of problems. Sometimes you'll have problems that arise because of a lack of understanding, or someone didn't have the right information, or one word was used out of context. And so So I just wanted to kind of do some investigating here, and I know that the person who asked this question can't really respond right now, but I think it's important to first know whether or not the client actually had Medicaid, and was it verified or was it through self-report. If it was through self-report, then he or she may actually have had a plan through the marketplace and not Medicaid. Copayments and deductibles are not common for Medicaid enrollees, specifically deductibles, especially deductibles ranging from $500 to $5,000. It kind of goes against the whole notion of health insurance for low-income individuals. If a copayment is requested of a Medicaid enrollee, which can happen, they're typically only $3 to $5, and federal regulations say that services can't be withheld for a failure to pay. And so it's kind of one of those rights thing where a person, if they know this and that is their right, they can say, I don't have to, you are still supposed to give me services even if I can't pay. But it's really rare for a provider to mandate a copayment, especially one for $500 to $5,000. Another explanation is that the client could be in the Medicaid spend down program. It is a Medicaid program, but it's a little different. And if a person has a lot of medical bills, but they don't qualify for Medicaid, they can bring their medical bills or send their medical bills to the state, and it could possibly allow them to qualify for Medicaid spend down. And with Medicaid spend down, they have to pay a certain amount of money every month before Medicaid can kind of help. And so they have to pay, and it depends on different factors for each person. So if someone has to pay $50 every month, then they have to show that to the state or submit that information before Medicaid will start covering anything else. But like I said, I mean, that's a really high amount that you showed in your question. The last thing, which Lindsay said earlier, was that if you guys have clients who are in the marketplace, another thing you might want to reserve your ARI funds for is for deductibles and premiums every month and for copays. And I know that there might be people, if someone's working and they're getting a job, they don't want to be, have their insurance taken away. And so it's nice that ARI has that ability to have maybe lose their Medicaid coverage, but it's a good thing because they're working. And so to be able to help with that, I think it's definitely something that you guys should explore doing. As Lindsay said, I think some sites are already doing that.
I'll just give a little more detail on that. At this point, we have seen that in at least one county's budget. And since this is an evolving process, that was a question they brought to us. And we were able to work with our legal partners here at CEJA and realize that that is something that at this point in time could be covered. And that could be worked in at the front end of your grant or through a budget revision or amendment process. So by all means, bring those questions to us. Obviously, having a fairly accurate idea of what the amounts are that could arise for deductibles will be very important, and that's something you'll know as you get familiar with the managed care plans that the marketplace plans that your clients might be in.
Yeah, if someone's in a marketplace plan, they will know how much they have to pay every month, if anything. In managed care, there's no deductibles. It's Medicaid. It's complicated, but if someone starts telling you they have to pay that much money, I think you can make that assumption that they're in a marketplace plan. Okay. But you should probably try to verify. Next one.
Great. Okay, another advanced question. A client has Medicaid insurance and they have a managed care policy. Treatment agencies won't consider them because, excluding the deductible and copayment, because it is out of network.
I talked about this earlier. As we said earlier, with managed care, you have to go to in-network providers. If there aren't any, there is the option for that provider to request a single case agreement with the managed care plan in order to keep seeing that person. which is typical in rural areas. The managed care plans usually have a process for this. They have forms usually available on their website, or you could request it from the plan. The provider is usually the one who does the requesting, but you can still gather that information and try to make it as easy as possible. It's something you might want to explore a couple times and see what works and what doesn't work, and then roll out on a larger scale. For the sake of time, I'll just go to the next one. The other question was, client has Medicaid and closest psychiatrist was in DuPage County. Not enough specialized doctors in the area. This is really the same answer as I said before. First, I would say to try to verify that there aren't any closer psychiatrists versus just relying on the ones that you are aware of. But if you did that already and there still wasn't anything, again, there's the option to do a single case agreement. There's also the option, if it's not too late, for the client to enroll into a different plan, a plan that has more providers. And we talked about that 5-month window of opportunity for that to occur.
So we're going to wrap up. We're just going to do one or two more questions, but I want to quickly get into this single case agreement thing, because that was a new term for me. And when I first heard it, I thought, does that really happen, or is that just a barrier that nobody can get through? And Katie Welter from Cook County Act Court told me that that's something they use. So I just wanted her to talk about that briefly so everybody knows that it can work.
Sure. So in the Act Court, a large number of our clients, their managed care provider is County Care, which is kind of a preferred provider in Cook County, and or at least a long-standing one, I should say. And one of our major treatment providers does not have a contract with County Care. And so we wanted to take advantage of the services that treatment provider offered, but somehow get around or kind of negotiate the fact that they weren't contracted with County Care. And what we did was we spoke with County Care and we spoke with the treatment provider, and and County Care said, well, we can accept a single case agreement, which means the provider applies to the managed care organization and says, I have this client is one of your members, and I have a Medicaid certified service to provide to them. Can I bill you in this single client case? And we have been successful in doing that. It's an additional step. It's an additional amount of paperwork. And so I would just advise proceeding carefully and be patient again. And if you can start with the managed care provider themselves and get them on the phone, ideally with the treatment provider, you can clear up any confusion in the beginning and avoid a situation where the client has received service or maybe has service terminated because the provider isn't getting paid. But it's definitely doable, and the first place to start is asking the client's managed care provider, how do your single case agreements work, and asking the treatment provider, are you willing to do a single case agreement?
If I may add to that, with those single case agreements, I know that downstate it is happening on a fairly frequent basis, and a lot of the providers are using it as a way of testing the waters with either MCO, that how are they going to be able to work together, can they work together, and it is occurring where they'll get the single case agreements and allow services to be rendered.
Great. Thanks so much, Craig. We'll do one last quick question, and then we'll wrap it up. And we really appreciate everyone staying on. So this is pretty general. What's the best course of action for an ARI site with just 1 or 2 local providers who don't take Medicaid and they're not with a managed care plan?
So just some options to understand whether or not their lack of participation is organizational choice, or if it's due to struggles to adapt to the Medicaid or managed care environments. I think I would also verify or confirm that they're the only providers in the area, or if they're just the only providers that you are aware of. If they are the only providers of the area, I think seeing if they're interested, or if there are others, to see if they're interested. If there aren't others, doing a single case agreement route, but then also explaining how many of your clients are now have Medicaid, and if you can, what percentage of them have which plan, and explaining to them the shift that's occurring right now, and that you might be forced to have to look for other options if this isn't what's working for the clients. And so I think having that conversation, and if it's not an organizational choice that someone's not going to operate in Medicaid and they're just struggling, I think we as the criminal justice community have the power to kind of help providers and to advocate that the infrastructure be protected that currently exists, and that MCOs contract with providers that we use. That's another thing, and so it's not really a straightforward answer, but I think there's advocacy in a lot of these answers to a lot of these questions.
Great, thank you so much, Cherie. We are going to finish up right on the 1:30 dot. Again, we really appreciate your participation and staying on to the end. We are certainly going to make this webinar and recording and slides available on our website, and we'll alert you when it's up in the near future and make sure that the entire network of ARI knows that it's there, so not just those of you who could join us today have access to it. So thanks so much to Katie from the Cook County Act Court, Cherie and Craig from TASC, and Sal Perry from CJA, who helped to coordinate this webinar. And as you know, we're here to answer your questions, so feel free to send them on. Thanks so much, everybody.
Thank you.